we tend to use point of care ultrasound because over the past several years, point of care ultrasound has evolved as a component of physical examination. Now, I really don't think, at least in the ICU environment, there is any physical examination without POCUS assistance. So when assessing these hemodynamics, you evaluate the hemodynamic circuit in three parts. The first one is the forward flow. You want to see how is the mean arterial pressure. You perform capillary refill test and so on. And then you assess the backward pressures of the heart. If the left heart pressure, it manifests in the form of systemic venous congestion. And VExUS helps you assess whether VExUS. You shouldn't be asking the question whether VExUS is a great tool to assess fluid responsiveness because that's a left heart. And so why are we worried about this connections in organ perfusion? When you look at the organ perfusion pressure, it's the difference between inflow pressure and outflow pressure. For example, in the context of kidney, the and central venous pressure or intra-abdominal pressure when it's elevated. So you can think of central venous pressure as organ afterload. So even if the mean arterial pressure is well preserved, if your organ afterload or central venous property needs volume depletion, but unfortunately, without using point-of-care ultrasonography, several cases of congestive nephropathy can be missed. So what is congestive nephropathy? It's essentially the same concept as organ perfusion pressure. So when the venous pressure is elevated, you have interstitial edema. That raises the interstitial pressure, which leads to inflammation, interstitial edema, and a tubular compression. And the tubular compression leads to increased intratubular pressure, and that will reduce the intraterminal pressure, which is frequently seen in these volume overloaded patients, adds to the problem. So VExUS or venous excess arterial vessels that are within the kidney to see if the elevated right atrial pressure, so here is the right heart, right? So if your right atrial pressure is elevated and being transmitted backwards, is it affecting the organ flow, the venous flow? And if the venous flow at the organ level is altered, how severe is it? So VExUS will tell you if venous congestion or not. And if there is congestion, what is the severity of congestion? So VExUS allows you to quantify systemic venous congestion. So the concept of VExUS comes from this post in Haifa cardiology. The one was the intervenient style that is more than 2 centimeters. Presence of severe abnormalities in atleted with a hazard rate of 369. So presence of flow abnormalities is associated with the congestive nephropathy. That's what this is telling you. And all these individual waveforms have been studied previously. So VExUS as a combination score or a method of quantifying systemic venous congestion is novel, but these individual waveforms are not new. Its applicability in all patients, and they're skeptical about it. But knowing this reassures people. And you may ask, like, we don't know, elevated central venous pressure is bad for organ perfusion. So just monitor this patient is the post-test of having injury was substantially higher with poor outcome in both cardiac ICU and general ICU cohorts. But the likelihood of development of AKI is significantly high. So, I mean, it's conceivable, right? So it's not just like when you have elevated right atrial pressure, you are saying that's going to the organ, and it's not just linearly transmitted to the organ. There is conduit in the middle, so there is vascular compliance in the middle, and also how the organ structure is of the transmission of right atrial pressure. These things play a role. It's very similar to your mechanical ventilation. It's not just so anyways, IVC is connected to the right atrium. So if the right atrial pressure is high, the inferior vena cava is plethoric. So the pressure is high here, the vessel gets bigger, and it's less collapsible during inspiration. Normally during inspiration, as the right atrial pressure reduces, the blood is sucked into the right atrium from the vessel. So the vessel collapses in spontaneously breathing patients. So if the right atrial pressure is high, the vessel is big and also less collapsible. And if the right atrial pressure is not so high, the vessel diameter is smaller, typically less than 2 centimeters or 2.1 centimeters. The normal diameter is 1.5 to 2.1, and it collapses by more than 50%. During inspiration in spontaneously breathing patients. That tells you the right atrial pressure is not elevated during 2 breaths. The collapsibility is not really clinically ventilated patient who has 2.5 centimeters IVC that's not at all moving with respiration. Yeah, most likely the right atrial pressure is high. Or you have a IVC of 1.1 centimeters that's completely collapsing during the respiratory cycle. Most likely the right atrial pressure is not elevated or low. In such patients, maybe you should search for hemorrhage or volume depletion, depending on the clinical context. So anyways, the point is IVC is used as the first step in VExUS to make sure the right atrial pressure is elevated. If the right atrial pressure is not elevated, probably these changes, I mean, there is nothing for the changes to be transmitted to the distal organs, right? So you probably don't need to perform VExUS. One caveat to remember is that like the 2 centimeters is arbitrary. It can't study done Canadian patients, so may or may not be applicable to people who have already so clinics. So look at the IVC. If it gets plugged at the IVC in a round like this, then probably it's getting fuller. Whether it's 2 centimeters or not. And in one Asian study, if I remember correctly, I think it's a Chinese study. They said that IVC more than 1.7 centimeters tells you that the right atrial pressure is elevated. So the point is use your clinical discretion. So hepatic vein Doppler. So let's go and talk about this individual components. The first one is hepatic vein. So hepatic vein, we have 3 hepatic veins. So we have the right hepatic vein, middle hepatic vein, and left hepatic vein. All these things go and join the inferior veins in the right. Here you can see the hepatic veins are these veins very easily, altering the venous blood flow. And you can access the hepatic vein from the side or from the subxiphoid. Subxiphoid, most of us who do point of care ultrasound are familiar with. You see an inferior vena cava and you see a middle hepatic vein usually that drains into the IVC. But for VExUS purpose, I would always recommend using the right upper quadrant. It's much easier to find the vessel there. You'll find a straighter segment for you to Doppler easily. So you put the transducer like this somewhere in the mid-axillary line, and you know that this is the inferior vena cava slightly to the right, and aorta is in the middle in front of the vertebral bodies. So your beam is coming somewhere like this, right? So say you're in you can use phased array or a curvilineage, which looks like this. Uh, you have liver initially, from the liver is what you will see. So you have the liver, and here you have the hepatic vein, like a little bit intersegment of the hepatic vein here. So it's easy to Doppler. Remember, to do Doppler, you need to have a parallel segment of the vein. Or in other words, the blood must be parallel to the blood flow must be parallel to the ultrasound beam. That would give you optimal images. And from the subxiphoid, this is a traditional IVC view, and you can see the hepatic vein joining. You can definitely do Doppler assessment here, but there are probably tiny collaterals here, and the segment is not always um, uh, long enough for you to comfortably Doppler. So most of the time, I find that you get disturbed flows from here. So obviously, if you don't have right upper quadrant uh, window where also intrarenal vein from there user, and you can see the transverse view of IVC. So this is a normal IVC, that's why it's more or less elliptical. You can see right hepatic vein, middle hepatic vein, and left hepatic vein. Usually middle and left hepatic veins form a single trunk to join the inferior vena cava. You can Doppler any of these veins. Traditionally, middle hepatic vein is commonly Dopplered, but I mean, there can be minor variations depending upon the vein, but you won't see like one vein is congested and one vein is not congested unless there is some significant local pathology. So how does a normal hepatic vein waveform uh, appear? So this is a very important waveform of the two because of the very waveforms. For people who are not very familiar with Doppler, um, you know that on Doppler, color Doppler ultrasound, red color indicates flow above the transducer. Sorry, flow, if your blood is going towards the transducer, that's manifested as red color. And if the flow is away from the transducer, that's depicted as blue color. So that's how red and blue are displayed on color Doppler. It has nothing to do with the vessel being Doppler or pulsed wave Doppler that we are using here. The If you have a tracing above the baseline, it's like red on color Doppler, which means the flow is towards the transducer. Flow towards the transducer is above the baseline, and flow away from the transducer is depicted below the baseline. And so with the basic concept, we'll see these, what these individual waveforms are. So we have waveform S, V, D, and A. S wave or the systolic wave occurs during ventricular systole. During ventricular systole, remember we are talking about the right side of the heart, right? In the atrium, there is a large amount of blood that goes into the right atrium. And on the hepatic vein, so hepatic vein is not this one, right? So hepatic vein is somewhere here, and the liver is here, and this is the IVC, and the blood is going from IVC into the right atrium. So in the hepatic vein, during systole, there is a lot of blood going from hepatic vein into the IVC. So that means the blood is moving away from the transducer. That's why it must be below the baseline. So this big chunk of wave here, that is below the baseline or antegrade. We use the terms antegrade and retrograde Remember, antegrade means it's towards central organ, that is the heart. Retrograde means it's away from the central organ, that is away from the heart. So these terms can be confusing. Anyways, the point is systolic wave occurs during systole. Towards the end of the systole, this tricuspid annulus starts to come back to its original position. So here is a S wave, it goes down because of increased right atrial pressure. That's called the V wave. And sometimes the V wave can be slightly above the baseline too. So it can go from here to here, and V wave can appear here like that. That's okay. Whether it's below the baseline or above the baseline, it's fine. It's a transitional wave between systole and diastole. And during diastole, the tricuspid valve opens, so there's more room for the right atrium to fill, and negative deflection or another antigrade wave, or another baseline wave called the D wave or the diastolic wave. Systolic wave is bigger than above the baseline because it's a flow away from the transducer in uh, the hepatic vein, or in other words, it's a backward flow. It's going into the hepatic vein here. So your small just represents at the end of diastole increased right atrial pressure. And A wave is absent if somebody has atrial fibrillation. So it's really important to relate hepatic vein waveform with EKG. Hepatic vein A wave follows the P wave of EKG, and S wave follows the R wave of the EKG, and D wave follows the T wave of the EKG. And hepatic vein waveform is pretty similar to that of central venous pressure waveform. This A wave is hepatic vein waveform as well. C wave, sometimes you can see, and most of the time you don't see. It's probably because it's slightly farther compared to your superior vena cava. And the V wave is V wave, and the X descent is the S wave, and it is D wave. So we have hepatic vein waveform as right atrial increases. Normally with the S wave is bigger than the D wave, A wave. As the right atrial pressure increases, the gradient between the venous return and right atrium reduces. Or you can imagine this better if you think of tricuspid regurgitation. So if you have tricuspid regurgitation during systole, there is a regurgitant blood flow coming to the right atrium, offering resistance to the S wave. So S wave becomes smaller and smaller as the right atrial pressure increases. So S wave becomes smaller than the D wave. Eventually, S wave goes and sits above the baseline along with the A wave, and eventually A wave and S wave fuse to just form one systolic reversal wave, and leaving only D wave or the diastolic wave below the baseline. I mean, you can nicely correlate with the EKG here. Always look at the QRS complex. So here is the QRS complex. The wave that follows must be S wave, and this wave is a D wave. So here, this is the QRS complex. There is no antigrade wave, or there is no below the baseline wave after the QRS complex. Only wave remaining is the diastolic wave. In general, if you see only one wave in each cardiac cycle below the baseline, that's most likely D wave, except in scenarios such as, say, pericardial tamponade, where you have diastolic collapse of the chamber. So D wave gets reversed. Use EKG whenever possible. Most of the machines have EKG slot. I mean, you probably have to buy EKG cable if it doesn't come with the machine. Usually, the cable is not that expensive, and it really reduces a lot of errors. For example, here, so this waveform, this hepatic vein waveform looks very normal, right? It looks, I mean, as good as possible. It's the same as the normal waveform that I showed you. So you can think of it as A wave, systolic wave. In the middle, you have the V wave, and this is the D wave. But when I put the EKG, does your impression change? So I put the EKG. So this is the QRS complex. So the wave that follows QRS complex must be systolic wave. So there is one above the baseline here. This must be V wave, and the D wave is here. So here in this case, S is less than D, indicating mild congestion. So it's very important to have EKG, no matter how many hepatic vein waveforms you saw or how confident you are. There is very high likelihood of making mistakes without it. Like more EKG related cases. So here, this waveform, so I'm showing you how I'm interpreting the waveform without EKG. The first waveform, to me, it looks like classic S more than D. That's what I would say. And this one is little tricky. It looks like there is one wave above the baseline, one wave below the baseline, one above, one below. It looks like maybe severe congestion. Maybe this is S reversal. And the third waveform here looks like this is the A wave, and I don't know what this is. And I feel like this is the S wave and D wave, maybe S less than D. And the last waveform here, it looks like S and D are of similar duration, or maybe, similar amplitude, or maybe S is slightly more than D. I would say it's pretty close to normal. But with EKG, let's see how these things change. And the first waveform here, this is a QRS complex, and the waveform that follows QRS complex is the S wave. So it's S less than D, so mildly abnormal pattern. Here, you can see the QRS complex here, and these two waveforms are fusing with each other. Here, one waveform starts in later part of one cardiac cycle and continues to the later part of the next cardiac cycle, which means there is a fusion of D wave of this cardiac cycle and S wave of this cardiac cycle, which typically happens in tachycardia, hyperdynamic hearts. So this is DS fusion, and the wave that you are seeing here is the V wave. So this is essentially normal. There is no congestion. I mean, the patient has tachycardia and the fusion occurs. And the third waveform here is interesting. This patient has prolonged PR interval. So after the QRS complex, whatever you're seeing is the systolic wave. So this is the V wave, and this is the D wave. So this is normal. So S is more than D here, as opposed to your previous inference of S less than D. And the additional wave is the atrial reversal wave because of the prolonged PR interval. There is more time in the heart to fill. So there is another wave. And the last waveform here is actually a case of atrial fibrillation. And after QRS, you're not seeing any downward wave here. It's only one wave in each cardiac cycle that's occurring during diastole. That's D wave. So it's severe congestion. So without EKG, you would have said like it's normal, but now you say severe congestion. That's not good. So yeah, that's the importance of having EKG. So let's quickly talk about portal vein Doppler. Portal vein Doppler is pretty easy technically, and also to understand the waveform. So portal vein carries the blood from your intestinal organs into the liver. So the blood flows towards the transducer, right? So your transducer is say maybe here, or in the subxiphoid area, the blood is flowing towards it. And after going into the liver, the portal vein divides into two branches, right and left branches. And you can access the portal vein from the same spot as hepatic vein. So once you find the hepatic vein, just tilt the transducer anteriorly. In this ultrasound image, observe carefully. So initially you have this hepatic vein. I'm tilting the probe anterior. Now you see this portal vein going into the liver. Let me erase the ink. Yeah. So initially now you're seeing hepatic vein here. I tilt the transducer anteriorly. You see the portal vein here. So this is the portal vein on a lateral window. So it goes and divides into two branches. And you can also access portal vein from the subxiphoid window. If you think about the anatomy, aorta is in the middle, inferior vena cava is to the right, and portal vein portal vein crosses the inferior vena cava and goes into the liver. So it's somewhere here, like almost attached to the IVC. So initially you see the aorta in this image. I'll show you, wait. So here is a hepatic vein. No, I think this is a wrong image. Sorry about that. Whatever we saw here, this is the same image. I forgot to put that. So normally what happens is initially you see the aorta in the midline, then you see the IVC, and then you see portal vein crossing over as you fan from midline to the right. But again, as with the hepatic vein, portal vein is also easily accessed from the right upper quadrant. And this is a portal vein line, and it's relatively continuous. So why doesn't display these S and D waves or waves analogous to central venous waveform? It's because there are hepatic sinusoids in between, right? So here is the IVC, which reflects central venous waveform, or hepatic vein for that matter. And in between, there are hepatic sinusoids, which act as resistance sites so that 100% of the CVP is not transmitted to the portal vein. The portal vein is here. And it's been long shown that so only a certain percentage of CVP is transmitted to portal vein. Even when the CVP is as high as 13, only about, say, 75% of the CVP is transmitted to the hepatic sinusoids. And what happens to portal venous waveform with increasing right atrial pressure? Normally, it's continuous, and as the central venous pressure is elevated, you can think of it as, um, let's see, what's the time? Okay, we are doing good. Um, you can think of it as the heartbeat being transmitted backwards because of the venous congestion. So it becomes more and more pulsatile. So this one here is pulsatile, and this one here is more pulsatile than the second waveform. And this one here is like very pulsatile with below the baseline flow or flow reversal below the baseline. This is severe congestion. Actually, this is also severe congestion. So in general, the pulsatility is less than 30%, which means in a given cardiac cycle, um, if you record the highest velocity and the lowest velocity, the difference must be less than 30%. 30 to 50% pulsatility is considered mildly abnormal. So this waveform probably has approximately 40, I would say. In a given cardiac cycle, I go here, I go here, or I go here, I go here. And this one is more than 50% pulsatility, this one and this one definitely. So more than 50% pulsatility is considered severely abnormal. And this is also severely abnormal here, but that reversal pattern typically happens when scenarios where portal vein can be pulsatile without elevated right atrial pressure. That's why it's important to interpret these findings in the appropriate clinical context. So it can happen in thin individuals when you're doing ultrasound workshop, or say you're practicing on each other. Sometimes young athletic individuals can have pulsatile portal vein at baseline. It's probably related to less sinusoidal resistance. But the point is, it's not necessarily abnormal. Even in cirrhosis, it can be pulsatile at baseline because of the arteriovenous shunting and also portal hypertension. This is an extreme case of portal hypertension where the portal vein has become completely blue. That means the blood is flowing away from the transducer now because of severe portal hypertension. So now the waveform is below the baseline, and though it's continuous, it's not normal, right? And obviously it's not reflecting your central venous pressure because there is something else, that is portal hypertension in this case, that's separating your portal vein from the central venous circulation. And the same patient, after liver transplantation, see how nicely the vein has become red again, and the waveform is above the baseline. Now in this patient, if this patient develops fluid overload or pulmonary embolism or some whatever pressure, pulmonary hypertension, you can use the portal vein to assess congestion. Let's see a real life example. There is a patient in surgical ICU who you are seeing. The patient doesn't have legs, meaning amputated, so it's hard to assess the pedal edema. You can't really assess sacral edema because the patient has some sacral wounds, and the patient is on mechanical ventilation. So, I mean, it's very difficult to assess intravascular fluid status or in this patient, and so documented fluid balance was positive 12 liters, right? And before doing the VExUS or POCUS, the question was, this patient was becoming hypotensive on hemodialysis. This patient had AKI requiring hemodialysis. So maybe this patient was volume depleted. And also this patient has intermittent atrial fibrillation. And whenever the blood pressure is slightly low, the surgical team was giving fluids. So there was a lot of things going on, and ultimately they point towards hypovolemia. But the documented cumulative fluid balance is positive 12 liters. That doesn't go with the assumption. So we performed POCUS. I'm just showing you the portal venous waveform. Here it's like very pulsatile, definitely more than 50% pulsatile with some retrograde flow. I mean, with some below the baseline flow. So that's severe venous congestion. So we put the patient on CRRT, and on exam 2, you can see there is no below the baseline waveform. The pulsatility has significantly improved after removing close to 4 liters. And then we removed 3.5 more liters, and it's almost normal. The pulsatility, I would say, maybe 30% or slightly less, which is good. But unfortunately, the patient got more fluids because of atrial fibrillation or whatever. So the night team thought the patient would benefit from fluids. And the next day I come in, the I do exam, the portal vein again became pulsatile. And I removed 5 more liters from prior exam, the portal vein has become completely normal. And unfortunately, the patient was taken to the OR again, got a lot of fluids. So his fluid balance has become positive 4 liters. And you can see that the portal vein has become like 100% pulsatile again. Now we removed more fluid and normalized the portal vein. So the point of showing this is that this is a great example showing how dynamic these waveforms are. It's not just about diagnosing venous congestion. That's not what I use for. In my general nephrology practice. I mean, I do ICU consult only, but the point is, in nephrology or maybe internal medicine practice, the real use of these waveforms is to monitor the response to decongestive therapy. Now coming to the last component, that is intrarenal venous Doppler. And when I say intrarenal, we are talking about inside the kidney. We are not talking about the main renal vein. That's very important to understand, because the main renal vein is like attached to the hepatic vein. Inferior vena cava. So the waveform can be pulsatile at baseline. It won't be as pulsatile as hepatic vein because it's a little farther from the heart, but still it will be pulsatile. But we are more interested in inside the kidney. Remember, we talked about kidney being an encapsulated organ. You have this interstitial edema and all that. So to reflect kidney congestion, intrarenal veins are more suitable, typically interlobar veins that pass adjacent to the medullary pyramids. Those are the veins you're going to ultrasound. And you put the pulse wave Doppler gate here, you get a trace like this. Venous waveform is below the baseline here because when your probe is here, in veins, these are the medullary pyramids, right? And you can see the adjacent blood vessels. The blood flow is away from the transducer for the vein, so it's below the baseline. And it's relatively continuous, similar to that of portal vein, because it's farther from the heart, and kidney is an encapsulated organ. So these two factors make it more continuous. And here, you don't need a EKG because like arterial waveform is above the baseline. That itself is EKG because these vessels are so tiny. Your Doppler almost always picks up arterial waveform depicted above the baseline. So you know this spike is systole, and this flow here is the diastole, systole, and diastole. If there is some alteration here in the venous waveform, you would know if it has occurred in the systole or diastole. So this is what happens to intrarenal venous waveform with increasing right atrial pressure. So this normally it's continuous with mild undulations corresponding to a wave of the CVP. And as the right atrial pressure increases, it becomes more and more pulsatile. So usually this pulsatility is more in between the systolic and diastolic waves. So in arterial waveform, this is the systole, this is the diastole, right? So you have this indentation between systole and diastole, and eventually the systolic and diastolic waves become separated. Uh, uh, and you'll see two distinct S and D waves. Essentially, it's like hepatic vein waveform now, right? So you have systolic wave, diastolic wave. And if you don't have the arterial waveform above the baseline, you can even see like A wave and B wave, the tiny waves like hepatic vein. And with further elevations in right atrial pressure, as you saw in the hepatic vein, the S wave gets reversed, and it's not seen because of superimposed arterial waveform, leaving only D wave below the baseline. So when you see D only pattern, that's severe congestion. And it's important to note that there is no data in advanced CKD patients, so you can have baseline abnormal waveforms, and that does not necessarily reflect central venous pressure, like you saw in hepatic cirrhosis, right? So you had abnormal portal venous waveform without elevated central venous pressure because of the local structural alteration. Same is the case with kidney. So this image was obtained from a nephrology clinic patient with advanced CKD, I think CKD 4 or almost 5. IVC was small, but you can see clear biphasic pattern with distinct S and D waves. And also for those of you who are enthusiastic about renal resistive index, you can see that there is only systolic flow. There is essentially zero diastolic flow. The resistive index is 1. It's not a specific thing. I'm not going to talk about RIs now, but the point is, I don't know how much to trust these venous waveforms if somebody has advanced CKD. So this is how VExUS grading looks like. So basically, we are now trying to put whatever we spoke about into one graphical form or into one chart to grade systemic venous congestion. So for the purpose of grading and simplicity, each waveform is divided into normal, mildly abnormal, and severely abnormal. In hepatic vein, S more than D is normal, S less than D is mildly abnormal, S reversal is severely abnormal. In portal vein, pulsatility less than 30% is normal, 30 to 50% is mildly abnormal, and more than 50% pulsatility with or without below the baseline flow is severely abnormal. In intrarenal venous waveform, normal is continuous. Mildly abnormal, when you see is biphasic waveform or two distinct systolic and diastolic. Severely abnormal is when you have SL leaving. So if you have a small collapsible IVC, no elevated right atrial pressure, there is no congestion. You call it grade 0 or no congestion. And you call it mild congestion or grade 1 congestion if the IVC is big, that is more than or equal to 2 centimeters, with any combination of the normal or mildly abnormal waveforms, which means there is no severely abnormal waveform here. You can have any of these waveforms here with a big IVC, then you call it grade 1 or mild congestion. Grade 2 is big IVC and at least one of these severely abnormal patterns. So say because the intrarenal is difficult, so you don't get that. So you got hepatic and portal. If at least if hepatic is abnormal, then at least it's grade 2 congestion. And grade 3 is IVC more than or equal to 2 centimeters with 2 or more severely abnormal waveforms. So you got only hepatic and portal. If both are severely abnormal, that itself is grade 3 congestion. Having intrarenal waveform is bonus. I'm telling this because intrarenal might be difficult to get in especially in critically ill patients. This is another classic example obtained from my heart failure patients. In one heart failure patient who the internal medicine doctor thought the patient was volume depleted or over diuresed, to be more specific, because the patient did not have pedal edema. And her diuretic dose was recently increased in the outpatient setting. Now the patient has acute kidney injury. Her primary care physician sent her from the clinic because of AKI. They were about to give fluids, but because of AKI, they called nephrology, and we performed physical examination. And physical examination is POCUS, obviously. So this is what I saw, the first set of images. Hepatic vein, you see only D wave below the baseline. Here is the QRS complex. So there is S reversal. Portal vein is 100% pulsatile with flow reversal. Intrarenal, you can see only D wave below the baseline. So this is the S wave. Here, there is no arterial waveform here. So you're seeing the S reversal nicely. The point is, this is severe venous congestion. At that time, creatinine was 2.6, sodium was 127. Assessment was severe congestion and start intravenous diuretic. So on follow-up, the sodium has improved. So it's hypervolemic hyponatremia, not hypovolemic hyponatremia as the internal medicine physician thought. And the creatinine has improved. So the congestive nephropathy is showing improvement. But the waveforms really didn't show much improvement. Yeah, maybe a little bit of S wave is coming below the baseline. Here, I mean, portal and intrarenal, I really don't see much difference. So based on this, we said, like, don't be in a hurry to discharge the patient. There is persistent severe congestion, continue IV diuretic. And on further examination, the sodium has improved to 135, creatinine to 1.7. And here it's very nice, like both S and D waves are below the baseline, but S is a little bit less than the D. It's almost normal, I would say. And the portal vein has become continuous. This is essentially normal. And intrarenal, you can see the S wave also starts to come below the baseline. So you have a biphasic pattern now. So now we said, yeah, portal vein has improved. I mean, it has normalized. So the gut congestion must be improved. It's okay to transition to oral diuretic medication. And on further follow-up, creatinine reached back to her baseline of 1.5. And portal vein has normalized, hepatic has normalized. Now you can see that the S wave is much bigger than the D wave very clearly. And renal, it's still biphasic, but again, renal takes a little bit more time compared to both these waveforms to improve because of the persistent interstitial edema. So this patient, no problem with discharge with oral antibiotic and follow-up in nephrology clinic. So just like a couple of slides about some important data. I mean, the VExUS study was done in post-cardiac surgery patients, so there might be some apprehensions about applying this to heart or other patients. So I'm just going to show a couple of slides on that. In a general ICU cohort published in abnormality, both like S less than D pattern and D only pattern increases the risk of major adverse kidney events at 30 days with the odds ratio of 4.3. In this study, portal and intrarenal did not show much correlation. It's probably related to the cohort being like ICU cohort, and hepatic vein is more sensitive um, to early changes of congestion. And in this study involving inpatients admitted because of the heart failure, 74 patients, they looked at IVC diameter, portal, and intrarenal pulsatory, abnormalities, and all. They also demonstrated that these waveforms improve by the time of discharge, and they found that VExUS grade 3 is associated with mortality. And a big IVC and intrarenal venous waveform pattern at discharge predicted heart failure readmissions. Readmissions is also a big thing because that consumes a lot of healthcare resources. If you discharge the patient without proper decongestion, or if you fail to assess congestion in these patients, which obviously the conventional physical examination is not adequate. And a recent study, I think this is published last month in December 2023, they looked at 125 general ICU patients with severe AKI who had pre-existing AKI, KDIGO stage 2 and 3, and more than 50% of who were mechanical ventilation. Abnormal waveforms are not present in a lot of them, but whoever had, like both VExUS 2 and VExUS grade 3, were associated with increased risk of mortality. That's important to note because in the original study, it was just VExUS grade 3 that was associated with AKI. And this study shows that both VExUS grade 2 and grade 3 are associated with mortality. So any congestion is not so good, not good. But all in this study, strangely, VExUS didn't really correlate well with major adverse kidney events at 30 days. It's probably because some of these patients already had acute kidney injury, and they take different time courses, and it also depends upon the multifactorial etiologies. Okay, and one question that commonly comes up is, can you distinguish pressure overload and volume overload using VExUS? No, you cannot. I mean, you cannot distinguish pressure overload and volume overload using CVP. You can't do that using inferior vena cava. You can't do that using VExUS. Essentially, there is no good tool apart from using your clinical judgment and interpreting the findings in the appropriate clinical context. I mean, some people frequently say that, I think it's probably not well understood thing, is that when you see D sign on focused cardiac ultrasound, that is in the parasternal short axis view of the heart, if you see a right ventricular enlargement compressing on the LV, that makes the interventricular septum flat, which means the LV, instead of being circular, becomes like D. And interventricular septum, when it's seen more in diastole, it's attributed to fluid overload, and when you see more in systole, it's attributed to pressure overload. But the distinction really doesn't uniformly apply, at least in ectogen. During systole, the systolic pressure in the RV must exceed that of LV. A RV that is normal at baseline without hypertrophy can never do that. So you don't want to rely too much on that also. So again, interpret in the right clinical context. There are more veins apart from hepatic, portal, and intrarenal. One vein of recent interest is femoral vein. Normal femoral vein is relatively continuous like that of portal vein because it's farther from the heart, right? And it can reflect a congestion. So there's a femoral vein in a severely congested patient with severe tricuspid regurgitation. You can see how pulsatile it became like that of portal vein that we saw previously. And these are another two examples of femoral veins that I have recently seen. You can see only like D wave with the help of EKG. You can see that there is no S wave here, only D wave below the baseline, which is again similar to that of hepatic veins, indicating severe congestion. Is this femoral vein congestion? So basically the point is like normal femoral vein is relatively continuous. Congested femoral vein is pulsatile. Remember it that way. And if you have EKG, you know what is D wave, S wave. How about this one here? Is this pulsatile portal vein? Without EKG, it appears like that, right? But with EKG, you can see that this thing here spans over multiple cardiac cycles. So unless each cardiac cycle is pulsatile, you can't call that a pulsatile waveform. So what's happening here is like this patient had a hyperdynamic circulation. I think it's a cirrhotic patient with small IVC that collapses with inspiratory changes coupled with cardiac cycles. So when the IVC collapses, you get a gap like this here. And when the IVC is open, you have increased velocities, giving this kind of waveform. And as I said, like femoral vein is farther from the heart. So you have continuous waveform. And also it's important to note that's why, because it's farther from the heart, it's less sensitive uh, to changes in the right atrial pressure. So you cannot use femoral venous waveform as a rule out test. If the femoral venous waveform is relatively normal or not so congested, only a little bit of pulsatile, you cannot say it's only mild congestion or normal. But if it is severe reversal, yeah, you can say for sure that there is systemic venous congestion. Remember that. I mean, there is a lot of interest because femoral vein is easy to perform. And when we are putting the femoral central venous catheter, you can probably access that easily. But it's not a substitute. Nothing is really substitute in the world of POCUS. You need a whole hemodynamic assessment. You can also do internal jugular vein assessment. It's very similar to hepatic vein waveform because it's central vein ultimately. And this is called VExUS or extended VExUS. Basically, what I'm trying to say is like you have these three traditional waveforms, but you can access other veins when you cannot access these veins or rely on these veins. For example, if the patient has cirrhosis, these two waveforms might not be reliable. In CKD, this might not be reliable, or you might not be able to get the intrarenal venous waveform. In those cases, you can try to access the internal axis in cava. You can do the subxiphoid window, or you can do splenic vein. And so with that, I would conclude. And I think I went 10 minutes more than expected. But if there's any time for questions, I'm happy to take. Otherwise, feel free to contact me on Twitter or I mean, this is my website, nephropocus.com, for more VExUS scenarios. Thank you.
Thank you, Dr. Abhilash. It was like precise and succinct, and definitely the questions that we will be getting in our chat box will be taking to you, and the answers we would be sharing with all of our delegates as well as attendees. It was excellent,
Sure.
and we really appreciate your effort in taking NephroPocus to the next level.
Thank you.
Yeah.
Thank you so much.
Thank you. Thank you. Have a great day. Bye. Bye. Take care.
Bye.